We're going to be talking about the Horner syndrome, and specifically we're going to be covering the pharmacologic evaluation. This is mostly for your tests purposes, because in the real world, we really have moved away from pharmacologic testing and just imaging the entire sympathetic axis. So just by way of review, the sympathetics to the eye is a three-order neuron arc, starting in the hypothalamus, descending posterior lateral down the brainstem, all the way down the spinal cord, to the C8, T2 level, the ciliospinal center of Budge. This exits from the spinal cord, arches over the apex of the lung, and in that location, a tumor called a Pancoast tumor can produce a Horner syndrome. Then it rises up the sympathetic chain, passing without synapse through the inferior and middle cervical ganglion to synapse in the ganglion of the second-order neuron, which is called the superior cervical ganglion. That is usually at the level of the jaw. Then onto the internal carotid artery. It goes up and back into the head, and in the internal carotid artery to the cavernous sinus, a short little piece on 6, and then V subdivision 1 through the superorbital fissure to the target organ. The sixth nerve is particularly interesting because a sixth and a Horner syndrome is known as the Parkinson's sign, and that is very good cavernous sinus sign. So we know we have a 3-neuron arc, the central pre-ganglionic primary, the secondary pre-ganglionic, and the third-order neuron post-ganglionic. So when we're dealing with a Horner syndrome, we're usually dealing with an anisocoria, and assuming it's unilateral, we have a little pupil and a big pupil. And so the first thing we want to do is make sure that the big pupil reacts to light and that the little pupil also reacts to light. So if the light reaction is good, then we know that we're either dealing with physiologic anisocoria or a Horner syndrome. And the way that we're going to determine that is to look in the dark. So in the dark, a normal pupil will dilate, and so the anisocoria will be greater in the dark in a Horner syndrome because the normal pupil will be dilating and the smaller pupil, the myotic pupil, will not dilate as well. And there'll be a dilation lag. That is, there'll be a lag in the time for the dilation of the Horner's pupil at 10 seconds versus 15 versus 20 seconds. And so the pharmacologic testing of the sympathetic pathway depends on the use of sympathomimetics. So we have various sympathomimetics, both direct sympathomimetics, which bind directly to the receptor, and indirect sympathomimetics, which do not bind directly to the receptor. They work by indirectly stimulating the release of or the reuptake of norepinephrine at the junction. So the most common indirect sympathomimetics that we have are cocaine, which works by inhibiting the reuptake of norepinephrine at the junction, and hydroxyamphetamine. So these two drops are used in the determination of both the Horner syndrome and localization. So if we put cocaine into an eye that has been denervated from a sympathetic lesion to Horner syndrome, it won't dilate as much as if we put it in the normal pupil. And we need to put the drop in both eyes so we can use the other eyes as control. So if we have a post-cocaine drop, anisocoria, that's greater than about 0.8 millimeters, you can have some high sensitivity and specificity that this patient has a Horner syndrome on the side of the smaller pupil. Cocaine, therefore, can only tell us if we have a Horner syndrome or not. It doesn't tell you whether you're in the first, the second, or the third-order neuron. In contrast, hydroxyamphetamine, which is also an indirect-acting sympathomimetic, but it acts in a different mechanism. It stimulates the release of norepinephrine at the junction, and therefore is a test of the integrity of the third-order neuron. So if we put hydroxyamphetamine into a patient who has already had a cocaine test, proving that it's a Horner's, and it doesn't dilate as well, then we know the problem is in that third-order neuron. If, however, we have a cocaine test that's positive and the hydroxyamphetamine dilates the pupil equally in both eyes, then we know we're dealing with a pre-ganglionic Horner syndrome, either a first-order or a second-order neuron Horner syndrome. The hydroxyamphetamine test, however, cannot differentiate between a first-order neuron and a second-order neuron. There is no test with drops that you can determine that because the drops are working at the eye. And so we can only test the integrity of the third-order neuron. And that means we can only tell the difference between a pre-ganglionic and a post-ganglionic using hydroxyamphetamine. You cannot tell first versus second. That has to be done with clinical testing or with imaging. Now, we have a different direct-acting sympathomimetic that we can use to confirm the Horner syndrome, and that drug is a lot easier to get and to use than the controlled substances, cocaine and amphetamines. That drug is called aproclonidine. Aproclonidine is a direct-acting sympathomimetic that has differential effects on the alpha-2 and the alpha-1 pathway. As you know, the alpha-2 is a presynaptic feedback control mechanism on the sympathetic innervation, and alpha-1 is the postsynaptic. And so, just like the drug clonidine, which is used for hypertension, even though this drug, clonidine, is a sympathomimetic, its alpha-2 effect allows it to be used as an antihypertensive. Likewise, aproclonidine has an alpha-2 effect, and even though it is a sympathomimetic, in a normal pupil, aproclonidine will either do nothing or cause a slight constriction of the pupil. Under conditions of the Horner syndrome, however, we have denervation supersensitivity and upregulation of the postsynaptic receptor, in this case alpha-1, and so aproclonidine will dilate a Horner's pupil and constrict slightly the normal eye or do nothing, and that often produces a reversal of the anisocoria. It is this reversal of the anisocoria that we're looking for, or the dilation of the myotic pupil, that confirms that this is a Horner syndrome using aproclonidine. So now you should know that we can use cocaine and aproclonidine to confirm the presence of a Horner syndrome and differentiate it from physiologic anisocoria, and we can use the hydroxyamphetamine once we have confirmed it's a Horner syndrome to differentiate whether we are dealing with a preganglionic primary or second-order neuron from a tertiary third-order neuron post-ganglionic lesion. And if you can't remember all these drops, in the clinic and in the emergency room setting, we're just going to image the entire axis from the hypothalamus all the way down to thoracic T2 in the chest. In the ER, that's a CT-CTA of head and neck to make sure it's not a carotid dissection, or in the outpatient setting, MRI and MRA, hypothalamus, the T2 in the chest, including, of course, the apex of the lung. So you should now know about the Horner syndrome and its pharmacologic testing.